It's another week that we talk about health matters. Good evening from wherever you're joining us. I'm Marie Yambo. Our social media platforms, that is at Marie Yambo and at KBC Channel 1 on Twitter, and it's on Facebook, KBC Channel 1 TV. We'd like to hear from you. Now, the World Health Organization, the WHO, has ranked cancer as a leading cause of death in children. Sadly, the rate of survival for children diagnosed with cancer is quite low, only at 20% in developing countries, and compared to developed countries where it is at 80%. This is mainly driven by the high rate of poverty, meaning families are not able to afford treatment and, of course, late diagnosis. Today in the program, we are discussing childhood cancer. Which are the risk factors and the challenges of funding? Well, with me in studio is Ruth Karanja. She is not just a breast cancer survivor, but a caregiver of children with childhood cancers. Dr. Kenneth Chege is an oncologist and a palliative care specialist. And did you know that cancer starts in the mouth? Well, here to tell us more is Dr. Emma Oinaina, who is a pediatric dentist and orthodontist who has dedicated the time to raise funds for treatment of children suffering from a childhood cancer. Welcome to the studio.
Thank you. Thank you.
Thank you. Well, without further ado, Dr. Chege, we'll start with you.
Yes.
And, just to help understand, we talk about cancer. But in this particular moment, we are actually categorizing it as childhood cancer. It will seem that this is just cancers that affect children.
Okay.
Yeah.
Thank you for having me. Now, when we talk about childhood cancers, yes, they are different from adulthood cancers. In which aspect? Because there are different kinds that affect children, and there are those that affect adults. Basically, we classify them according to the frequency. For example, in childhood, we have what we call non-Hodgkin lymphoma. That is the most common. And the most type that we find around is what we call Burkitt's lymphoma. Then at second, we have what we call leukemia. It's quite common. Then we have a neuroblastoma. We have nephroblastoma. We have rhabdomyosarcoma. We have osteosarcoma. Those are pretty common cancers in childhood. Mm-hmm. If you compare to the adult, we talk about breast cancer maybe, we talk about cervical cancer, we talk about prostate cancer, esophageal cancer. Those are mainly the common type in adulthood. Mm. Yes, so that's the difference.
Okay.
Yes.
And when you talk about childhood cancers,
yes,
are we looking at age brackets that this disease is likely to, affect a child?
Okay. Maybe if you go by our statistics, the frequency, we find it at between 2 years to 8 years. That is where major category will find that we are diagnosing our childhood cancers at age of 2 to 8. However, there are those that you can find existing at utero, mean before birth. There are those that now will persist beyond the 8 years, find them at 13 years. But cumulatively, you find them at age of between 2 to 8 years, thereabout.
Okay.
Yes.
And you've already mentioned the types of childhood cancers.
Yes.
So maybe just briefly,
yes,
you could, explain to us,
yes,
just briefly. I know there is leukemia,
yes,
and all that. So maybe you can just tell us how it expresses itself,
okay,
which part of the body,
okay,
it affects.
Okay, good question. Now, I think we start defining what is cancer, because as we go looking at the symptoms and the presentation, we need to define what is this cancer. Now, in a normal occasion, everybody has cells. Cells is the basic unit of a living organism. Now, the cell has what we call regulated growth, meaning it is controlled so that it has the population and it has its own death. Now, in instance when we are classifying cancer, the cell itself loses what we call, it gains what we call immortality. So it is unregulated. So it can spread everywhere. It can grow uncontrollably. So when we define cancer, we call it as a spectrum of disease characterized by abnormal proliferation of cells. Now, majorly in children, their symptoms seems to overlay. What I mean, they overlay sometimes. There are those classical signs you will see, and then it will hit you I'm thinking of malignancy or cancer before you define which type of a cancer it is. Because now cancer, first of all, you have what we call suspicion, high suspicion. Yeah? When you suspect, for example, is then when you investigate and you classify accordingly. Now, what are these symptoms and signs?
But maybe, Doctor, before we get into the symptoms,
yes.
we'll get to that very soon.
Okay.
I would just like us to, especially the common ones in Kenya.
Yes.
What are those types of childhood cancers that you're seeing?
Yes.
Commonly diagnosed here in Kenya.
Okay.
We'll get to the symptoms so that people can understand what to look out for.
Okay.
Yeah.
Now, the most common is what we call non-Hodgkin lymphoma. It's called a lymphoma. And the most common type is Burkitt's lymphoma. Burkitt's lymphoma, actually, most commonly, they will describe as a swelling, most on the jaws, first of all. Then it has a very good characteristic. Sometimes it has what we call self-doubling rate of 48 hours. Meaning, you have, maybe you have gone to a clinic or a hospital, with maybe incident of finding of a swelling, for example. So your doctor has examined you and then maybe has recommended an investigation like maybe a CT scan. So as you're thinking to do a CT scan, maybe gathering the finance, you take 2 to 3 days. You go back very fast and then say, this is abnormal. The swelling itself, it has doubled in size. That is the Burkitt's lymphoma. Now, leukemia comes second to lymphomas. Leukemia is maybe the ALL, we call acute lymphoblastic leukemia. That is the most common. Then we have AML in terms of leukemia, acute myeloid leukemia. Then when you find maybe incidental findings, maybe this to the practitioners or the caregivers, maybe abdominal swelling. You just maybe cleaning your child and find that there's obvious swelling. That one will now give you a clue of what we call neuroblastoma and nephroblastoma. Now, any other incidental swelling that you find anywhere can be what we call rhabdomyosarcoma. Now, maybe other characteristic would be when somebody is complaining or the child is complaining of pain, non-specific pain, limping, that one can also give you an indication of osteosarcoma. So that is how they flow, according to the hierarchy. Those are the most common types.
Okay.
Yes.
Ruth, you have an interesting story. Not only are you a caregiver for children with childhood cancers right now, but you're also a breast cancer specifically, a survivor.
Yes.
We'll be getting to that. I know we'll be having a program specifically to talk about that. But what are you seeing as a caregiver when you go to visit, these families whose children have cancers? What are some of the things that you're seeing happening there?
Mostly is ignorance, because many parents, they just ignore. And because maybe even that effect does not cause pain, so they just ignore. They go for something to lab, hot water, and anything to calm that. And they just ignore, and then until it goes to another stage. And then they lack finance, because if you think of going to the hospital, you need money, and maybe even 100 shillings, it's a lot of money to many parents. So you just say, it's okay, they'll get well. So many parents lack basic needs, even food, even shelter, even education. So they live in a total mess.
Okay.
Yeah.
And definitely, I mean, in that state, that means they don't take action very fast.
They don't take action very fast.
Of treatment.
Yeah.
And
even when you tell them to take action, they just wonder how now. And you cannot go and take a child to the hospital when the parents are there, and it's critical. You cannot just go and say, I'll take the child to the hospital, unless they are willing. They don't have that willing.
And it all boils down to funding, really. It's the money and, to access hospital and all that. And that's where Dr. Wainaina will be coming in later on in the program.
Yes.
But, it's interesting that we were talking earlier, Dr. Emma Wainaina, and you as a pediatric dentist, you said it's actually very easy to diagnose or get to know that a child is suffering, or someone is suffering from cancer for that matter. So you said that it's possible to actually diagnose or at least see the symptoms of cancer just by looking at the mouth, even as Dr. Shege will be explaining to us more of the symptoms.
Yes, normally what we noticed as dentists when we actually see these kind of cases, we have these non-healing ulcers, just don't heal. They take antibiotics, they take painkillers, but they continue just, if anything, just growing and becoming more painful, so the ulcer just keeps on bleeding all throughout. So that's when we're like, we need to take a biopsy and actually find out, because most cancers actually come this way. You have non-healing cancers, whether they're on your skin. Most of them are the oral cancers. They could be on the inner surface of your cheek, on your tongue, on your palate, and down at the bottom on your throat. We'll see all these ulcerations, and they're not healing. And you'll find this in children, and you'll find this in adults. And yes, the Burkitt's lymphoma that Dr. was talking about, that's actually a jaw. The lymph glands are affected with the jaw and the mandible, and it actually doubles in size. 48 hours later, you can't believe the mass. Another 48 hours later, it actually doubles. And it's frustrating for the child because they're in pain, they can't swallow anything because also their throats are actually being compressed. It's one of the saddest diseases, yet it's curable. Once it's caught early, it's curable.
Yeah, okay. So are you saying that, by looking at the mouth, you can actually tell any type of cancer, or it has to be the kind of cancer that affects the jaw?
Not any kind of cancer.
Okay.
Most common cancers will be the squamous cell carcinoma cancers. And those ones you can actually detect, and even when the biopsies are taken, we actually confirm that those are the kind of cancers that we find orally. Okay. However, still screening is necessary. So that's how Ruth actually missed out on that. Screening is actually important. And that's why we tell people, whenever you have your medical covers, the ones who can afford it, go for a screen. Yeah. Even with NHIF covers, you can actually get to screen yourself.
And actually, you'll be talking to us more how you're actually trying to help, some of these poor families, come up with the NHIF cover and all that. But coming back to you, Dr. Shege, maybe somebody listening to us right now, they have a child who has been complaining of one or two. What are some of the symptoms that you could actually say, if you're seeing 1, 2, 3, then it's time to actually seek more medical advice?
Okay. Now, we start with the obvious thing will be weight loss. Any weight loss, sometimes in oncology we quantify as 10% within 6 months. But any weight loss that you are noticing, supposed to now seek an opinion about it. Now, other thing will be fever. So that is unrelating fever, means fever goes, comes, and then fever is always indicative of infective process, inflammatory process here and there. So when it is on and off, you need to know what is happening. Now, another pattern will be drenching night sweat sometimes. It happens. So you find you're changing your sheets, it's happening. Now, the other obvious things will be like, for example, swelling of lymph nodes. That is common, I think. When you look at your child, you can see like a small swelling there. You need to tell your doctor, there's something I'm noticing here. What is this about? Now, another thing will be recurrent infections. That is common. And when you go to the hospital, sometimes they do what we call full hemogram. That is common everywhere in this country. So when they do the full hemogram, sometimes you have gone first visit, a repeat visit, and a repeat visit about the recurrent infection. Now, and you have done the full hemogram. Maybe if your practitioner is able to look at it and tell you there's some differences he's noticing, well, that is okay. But if you have done that repetitively because of recurrent infection, now this needs to have a good second opinion. Now, another thing that we usually notice will be anemia. Anemia, will know it by maybe lethargy, weakness. Mtoto hana nguvu kabisa. Then another thing that will come from anemia will be the bleeding pattern. maybe a child is playing here and there, a small injury, you will see a pattern, maybe something we call ecchymosis, a type of bleeding. Those are the most common things that you will notice. Yes, other things that you cannot, of course, miss is obvious swellings that you see anywhere.
Yeah.
That one tells you something else is going on. Let me consult.
Okay.
Yes.
And you know, Ruth, as a caregiver, you know, having yourself, suffered from breast cancer, and now you're a survivor.
Yes.
You already have that experience in itself. I don't know, how do you engage these children in terms of encouragement? What do you tell them, or how do you talk to them?
Yeah, one thing, you show them love. You show them a lot of love. You show them that they care and support, yeah? And you tell them that it is well. Always it is well. So they should not be anxious. What will go on after? Just tell them with a lot of love, with a lot of courage, with a lot of confidence that it is well. And then show them that you care. Yeah, and
you gave me a story of this, is it a standard 7 girl?
Yes.
Whom you even show them your injection marks,
yes,
during chemotherapy.
And even my removed breast. Yes.
Yeah.
Yeah.
Okay.
And when you show them the scars, and even now, that time I started visiting there, the hair was growing, and the girl, the hair had gone. So I could tell her, you see, and it comes back like a sound, you know, with laughing.
Yeah.
And she could even laugh. So I just tell her, it is okay. It is okay. Just accept, and you are going far. You'll grow, you'll reach my age and continue. So you give them hope.
Okay.
You give them hope with a lot of love, with a lot of courage and confidence.
Yeah, and you know, Dr. Shege, when Ruth is talking about giving them hope, and you know, the mindset of the child, you were telling me, it's actually very different from adults, and definitely because adults have all manner of stresses to deal with. But the survival rate for children seems to be quite high, simply because of their conceptualization of, can I say, what death is, or what cancer means.
Conceptualize death.
Yeah.
But adults do. So an adult will even give up on the day of diagnosis. There's some who will give up, they'll despair, and they'll have a negative attitude. And in fact, it's people like Ruth who have great positive attitude that actually survive. And children are usually positive in nature. So as long as they can get their food, their play, they're happy campers. And they'll actually survive. Yeah,
and you mentioned to me some of the activities that you organize for the children so that life looks like normal.
Yes, the foundation that we support, it's Hope for Cancer for Kids. They have all these art programs where kids come and draw and behave like kids. They also have games where kids come and have a small competition and act like kids.
Yeah.
So the minute you allow a child to actually come out of their boundaries and actually enjoy living, their attitude changes. They don't feel sick and sad. Yes, one day they'll be sad because of the chemo or the radiotherapy, and he'll not be off or on, and then the next day the child is up and about, bouncing up and about. So it's that kind of cheery feeling and the cheerfulness
that brings the healing.
Brings the healing.
Okay. And you know, Dr. Shaged, somebody may ask, I mean, you know, you've mentioned between, is it 3 years to 8 years?
Yes.
Where they're at risk
Yes.
of getting cancer.
Okay.
As grown-ups, we know that lifestyle can
Yes.
actually, you know, lead to you getting one form of cancer or another.
Yes.
But with children,
Yes.
are there risk factors, and is it also genetic to some extent?
Okay. So when you talk about genetic to some extent genetic, it's roughly 1 to 2%. And majorly we mention what we call retinoblastoma. And that's why you'll find sometimes we do what we call family counseling or genetic counseling, so that when we have done a diagnosis of retinoblastoma, for example, we make the caregiver aware that this can run within families. So we look at, we actually now tell you to be on toes in terms of screening. Screening is very simple sometimes, because for retinoblastoma, for you to notice retinoblastoma, you'll see it yourself with just a mere touch. You see, you shine it, there's what we call white reflex. They usually see it. So that is majorly common. Others, now, the other percentage, about 95, we will not talk about them being genetic. But now, anything about cancer, majorly, talk about what we call genetic mutation. That means a gene has changed. So when it has changed, there's something that is lost, that the regulation that is lost. Now, that is what we call, and it's majorly what we call sporadic, instantaneous. It's not something that you can predict what has caused this one. It's just sporadic. So we talk about being genetic mutation, that is one. We talk about now the hereditary being about 1 to 2%. Now we go to maybe the exposures. The exposures from maybe chemotherapy. For example, we talked about the most common type of lymphoma, like Burkitt's lymphoma. For example, if you're getting the chemotherapy, you're predisposed to getting another type of cancer, for example, AML, ALL, that's a type of leukemias. So it is not uncommon, or it's very common when you're treating one type of a cancer in a child to realize another form has arisen. Now, history of irradiation, that is from the radiotherapy itself as a treatment modality. Now, exposure to the environment may be the benzene. Benzene is a type of a chemical. Those who live near industries, but it's not that common. So the lifestyle, we don't play around with it because it doesn't contribute so much.
Oh, okay.
Yes.
Yeah, and you know, all talking about childhood cancers and all that, there's always the difficult thing of treatment. Yes. Dr. Wainaina.
Yes, treatment is available, it's just expensive.
Yeah.
And it's because cost of treatment is also equally expensive. The machinery is expensive, the medication, the drugs are also expensive. So you find children actually bearing the brunt.
Yes, Ruth, probably you can now give us your parting shot.
Okay. The most important thing is to give awareness, mostly to the mothers, because they should not ignore anything that they show in their children, and they should take a lot of care and go to the nearest hospital for consultation.
Okay.
Yes.
Thank you so much, Ruth. Dr. Shege, what message you'd want to pass to the people out there?
Okay, my comment would be, let's be aware that childhood cancer is common. We are dealing with it currently. It's not about myth, so let's go for checkup. Should you notice something that is obviously alarming, go to the nearest facility. Then again, I would say referral is very important because early diagnosis is equal to a good outcome.
Okay.
Yes.
Dr. Wainaina?
Yes, so as Dr. Ria said, that we need to actually get this disease early so that we're able to actually get treatment. So me and my colleagues of BNI. BNI stands for Business Network International. We are actually having a fundraising dinner on the 5th of November at the Radisson Blu. And what we want to do is to save a life. We want to save the lives of these children. We want to pay for the NHIF, which is $6,000 per annum, so that we're able to have these children get access to treatment and therefore actually survive and become cancer survivors. So that's what we want to do. We're saving a life. We're bringing back these talents that are dying. We, the community, deserve to have these children living. So let's save a life. Join us 5th of November at the Radisson Blu. BNI will be having a fundraising dinner event for these children.
Indeed, save a life. Thank you so much, Dr. Wainaina, for coming into the studio. Ruth, thank you so much also for coming in and being able to talk to us about your experience as a caregiver. Dr. Shege, oncologist, also giving us your experience in terms of treatment and even just enlightening our viewers. So thank you so much for coming to the studio. And also thank you so much for taking the time to be with us this evening. It's been, I think, a very educative moment, and I hope you've been able to also learn a lot. And also, if you have a child and some of these symptoms, you can relate to, it's advisable that you seek medical attention as soon as possible. So thank you so much. My name is Marie Yambo. Until next week, it's bye for now.